Special mention to Nelson for facilitating this event today. Mine is to introduce our honorable speakers. We have the first speaker will be Dr. Nakitari, who is a rheumatologist. We work together with her. She trained in South Africa. She's done great work, some research, and she's a great clinician. The other presenter will be Dr. Lawrence Owino-Kongo, who is our pediatric rheumatologist, trained in South Africa, lots of research, pioneer pediatric rheumatologist. And the other speaker will be Geraldine Kirote, pioneer rheumatology nurse, trained in Glasgow, and a short speech by myself. Of course, World Arthritis Day the aim is to create awareness about arthritis in general. We know there are more than 100 types of arthritis. We were not able to cover all of them today. Many times we have covered on rheumatoid arthritis. Most likely next time we'll cover on osteoarthritis. But I'm happy to introduce Dr. Nakitari, who will make a presentation on gout. Welcome, Dr. Nakitari. As I mentioned, she's a rheumatologist at the Rheumatology Unit, Kenyatta National Hospital. Did her training in South Africa, several publications, contributed to the EULA textbook of rheumatology. So she's done great work. Thank you very much and welcome, Dr.
Sorry, Dr.
Nakitari?
Yes, sorry, I had forgotten to unmute my speaker. I just wanted to confirm that you can hear me.
We can hear you loud and clear.
And you can see my slides?
Yes, we can.
Okay, so thank you for this opportunity to discuss gout on this day of to celebrate or to more disseminate knowledge about arthritis on the World Arthritis Day. My name is Dr. Nakitare. I will give some perspectives on gout, and whatever we may not discuss, perhaps in the question and answer chat, one can have some questions. So probably the reason why we wanted to discuss gout today is the fact that it is actually a common form of arthritis. Out of all the inflammatory arthritides, it is thought to be the most common. And over time, we have come to the realization that it is probably the fastest growing or the arthritis with a very high incidence of late. For the last several decades, we found that the increase in the number of cases of gout that have been identified has gone more than tenfold. And apart from the fact that we have an aging society, we think that our lifestyle may have also something to do with this high or rising incidence. And most of the time, when we talk about gout, we think about men, but as we'll be discussing a little bit later on, females can also be affected by gout. So why should we discuss gout today on this World Arthritis Day? Gout has been shown to be associated with an increased risk of mortality, particularly from cardiovascular disease. It is also a significant cause of morbidity because when you have acute gout, it actually interferes with your quality of life. You may even be unable to go to work or do your normal things. And when you have chronic gout, you may have disability in addition to the other cardiovascular disease that one may be dealing with. We also think that hyperuricemia by itself contributes to worse outcomes in some of these chronic illnesses. And in some literature, some authors may argue that hyperuricemia is probably a non-traditional cardiovascular risk factor. And so we need to identify it early and manage it early. So when we are thinking about gout, let us think about who the typical patient is and how they might present. So the typical patient is usually male and of a certain age, usually starting to approach middle age and growing older. So maybe a gentleman, maybe in his 30s, going into his 40s, and of a certain lifestyle. Most of the time we describe the typical patient as being one who frequents bars, takes alcohol here and there, eats meat and leads probably a sedentary lifestyle and has other conditions, though this lifestyle does not necessarily include all the people who might have gout. You can find quote unquote sober individual who probably is a vegetarian who can still develop gout. And therefore there are other factors besides lifestyle. Family history or genetic factors actually contribute a lot to the risk of developing hyperuricemia and the risk of developing gout. And there are also other medical risk factors, which we will demonstrate in other slides. So the patient who has gout, most of the time you may meet these patients when they are going through an acute gout attack. Probably later on when they have advanced gout, of course, you identify them because of the joint changes and other clinical symptoms that you see. But let's reflect for a moment on the acute gout patient. So on the left of this slide, you can see a table there where we are describing some of the things that one might use to identify that this patient is actually likely to be having acute gout or having gout. So the first thing is that they have pain in a joint, and this pain is usually acute. So gout is one of the causes of an acute arthritis. And the pain is so acute that it can develop to its maximum within a matter of hours. So within, let's say, about 24 hours, you've already moved from 0 to the maximum amount of pain that the patient might have. They also exhibit the usual signs of inflammation, including redness of the joint, pain, warmth of the joint. They may even have fever while they're having this episode. Many times this acute gout will occur at night and will often involve the feet, more specifically the metatarsal joints, usually the first metatarsal joint, but any other joints of the foot or the ankle are more commonly involved in an acute gout attack. And then there are other factors about that, but I wanted us to just reflect a little bit on the way that patient may present to us for the first time. With time, of course, if they develop established gout, gout may present as a polyarthritis that resembles rheumatoid arthritis. But let us keep in mind that we need to have somebody with features of inflammation, with a very rapid onset and rapidly increasing pain. And when it is in that phase of acute gout, it tends to resolve by about 7 to 10 days. Within 2 weeks, it can resolve, even without medication, may resolve by itself. Okay, so let's discuss a few other things. We are talking about hyperuricemia, meaning that we are talking about uric acid. And we want to point out that uric acid can either be overproduced or underexcreted. And the main problem in gout is an issue of underexcretion from the kidney. And the kidney is actually probably responsible for about 60 to 70% of uric acid excretion. And so if there's a problem there, then the patient is likely to have a higher risk of gout or hyperuricemia. The gut may also be involved in that. Overproduction is a factor, but not as prominent as underexcretion. I mentioned that women can get gout, and the women who can get gout are usually menopausal or postmenopausal, and they may have other comorbidities such as osteoarthritis, hypertension, and CKD. And they tend to have a polyarticular presentation, polyarticular meaning many joints, and they may present with tophi. Now, usually younger women, it is unlikely for younger women premenopausal, less likely for them to get gout unless they have a family history or a genetic tendency. So it has been reported, but it is less likely. So routinely ordering uric acid in a 25-year-old female who has joint pains perhaps is not the best use of their resources unless you have a very specific reason. We also want at this point to remind all of us to remember that there are differentials for gout, and when you have a monoarthritis, of course, sepsis is always the main differential, but remember there are other crystal arthropathies that can present like gout. So what are some of the triggers and associations? We've talked about that acute gout and the way that it presents. We want to remind ourselves about the triggers that can tip somebody who has hyperuricemia to develop an acute flare, or somebody with established gout to get an acute flare, we need to be cognizant of factors such as an acute illness, dehydration, dietary indiscretion, use of uric acid lowering therapy, exercise, drugs, trauma, radiation, and fructose, which we'll also discuss a little bit later, and physiological stressors. They can all trigger gout. We also want to mention that gout is associated with comorbidities. It is associated with a number of cardiovascular risk factors, including the traditional ones: hypertension, chronic kidney disease, type 2 diabetes, myocardial infarction, stroke, and obesity. So if you meet somebody and you diagnose gout or you suspect gout, you should make sure that you assess them for these other cardiovascular risk factors and manage them appropriately. The dietary and lifestyle factors, we have mentioned a few, and we all know the traditional dietary factors that we all tell our patients about to avoid purine-rich food. And some of these purine-rich foods, if you look at the center of my table there, sorry, there are some dietary influences. Let's have a look at this middle column here, where we can see these high purine foods, and we have examples like red meat, like liver, offal here, meaning the muturas and the other innards of the animal, and shellfish, which, well, we don't really consume that much in this society, crabs and so on, but we do have the rise of the bourgeois and others who may be consuming this kind of food, so crabs and prawns and so on. Want to point out for all of us that fructose and sugar sweetened drinks are also a factor in influencing gout, hyperuricemia. So we should remember to check this in the diet of our patients. Alcohol, more beer than spirits. And then there is this list about what is associated with lower urate. You can advise your patients, but I don't know how easy it would be, you know, how many cherries should they eat. And we don't really advocate for giving vitamin C supplements to patients, but these are some of the things just for our knowledge that may reduce urate. We talked about genetics. Let's move to this first column here on the left. And there are these various genes that code for the transporters in the kidney. So if there's a problem with them, this patient will be more likely to get gout or at a higher risk. We also have other deficiencies that affect the metabolism of uric acid. On the right, let's look at a few clinical associations of choice just to remind ourselves. Of course, when you have malignancies because of the high cell turnover, but to remember the chronic kidney disease and psoriasis. And of course, we've already mentioned those cardiovascular diseases. And then let's also mention one or two drugs that if you're taking diuretics, and if you're taking drugs like cyclosporine and tacrolimus, which we also use in rheumatology, but are also used in other disciplines, you have to be on the lookout for this. Other medications that you can use in somebody who has gout when you're trying to treat them, try to use losartan if you're able to control their blood pressure. It is thought to reduce serum uric acid, and calcium channel blockers and atorvastatin if you can have that, if it is indicated. Okay. Now, just to mention that when you're diagnosing gout, the gold standard is to look for uric acid crystals or monosodium urate crystals in the joint aspirate. And here is a picture of the typical negatively birefringent needle-shaped crystals that one might see if you do polarized microscopy. I don't know how readily available it is. Even in Nairobi, I think maybe we don't find that very readily, but it is done, I think, at the University of Nairobi and some other laboratories around. This is the gold standard, but as we shall see that if you're not able to do this, there are other ways that you can diagnose gout. If advanced gout can cause erosions, you can see there where I'm pointing with my arrow in the X-ray of some of the joints. You can do an ultrasound, and this is what is called the double contour sign. And nowadays there's a special CT scan that can also reveal some of the uric acid deposits if you have the capacity to do that. Okay. So let us suppose that you're not able to get your monosodium uric acid crystals. There is a gout classification criteria, note I've used the word classification, that you can use and apply to your patients to help you wherever that you are. And these are available online for free. This should be the 2015 version. So gold standard, get some joint aspirate look at the fluid, look for the crystals. Try to do that. You can also aspirate TOFA if you wish to demonstrate the crystals. But if you cannot do this, then you want to first of all make sure that this patient has an arthritis, because you need to, gout is an inflammatory arthritis, therefore you cannot diagnose it without demonstrating that there's been an arthritis. You cannot confidently diagnose it without demonstrating arthritis. Okay, so if you cannot get your uric acid crystal, but you have a patient with arthritis which you think could be gout, then you can apply these other criteria, and these are available on your internets and all that. So you don't even need to take a big note of it. Just know that if you can score more than 8, then you are likely to be dealing with a patient with gout. Remember that there are these descriptions that if the lower, the foot is involved, more likely to be gout. If there's evidence of more inflammation, more likely to be gout, and descriptions of that pain, as we've said, the time to maximal pain is usually 24 hours. If you have a TOFAS, you can see it gets quite a lot of points. And then there are laboratory issues about measuring the uric acid, which we want to remember that uric acid can be normal during an acute gout attack. Therefore, a normal uric acid with an acute gout attack does not necessarily exclude gout, and you may want to measure that uric acid on another day. Imaging can also assist. Okay, so as we've already said, gout has a sort of natural history. So you have people who have what we call asymptomatic hyperuricemia. Just because you have asymptomatic hyperuricemia, which means high uric acid but no other symptoms, it does not mean that you have gout. It also does not mean that you will inevitably develop gout. You need hyperuricemia to diagnose gout, but just because you have it doesn't mean you will get gout. So one has to be careful in who you label as gout and who you label as hyperuricemia. But once somebody moves from this level of hyperuricemia to the level of where the crystals are getting deposited and they're getting symptoms, then you are moving towards the place where you're diagnosing what we call gout. It does take time. From the first acute attacks of gout, it takes time before you develop established gout, maybe about 10 years. So it is important to pick these patients early and prevent them from getting to that established gout stage. And that's why we have a place here which is called intercritical gout, where the flares are starting to get too many and the patient is now moving on to the stage of established gout. Okay. Now, let us suppose we've had a patient who has acute gout, we've tried to diagnose, we have the symptoms, maybe we have got our aspirate, we have crystals, and we think that this patient has acute gout and we need to treat them. So we just want to remind ourselves, what should we do? Probably this is most important for all of you who are managing patients out there. So the important thing, of course, is to manage the pain and discomfort that the patient has. And before you even get to the pharmacologic interventions, ice packs have been thought to be quite effective as a non-pharmacological management. So don't hesitate to use them, or tell your patient that if you have an acute attack in the house, before you get to the hospital, why don't you get some ice or something cold from the fridge, put it on the joint, it will actually reduce your pain and discomfort. Okay, so what options do you have to treat this patient? Of course, we all know that non-steroidal anti-inflammatories have been used of all variety. There may not be one that is preferred over the other. It is really about what is available to you and what you prefer. But, you know, examples that are given here include naproxen and the coxib groups and so on, with suggestions that you could start at a higher dose for about 3 days and then reduce the dose until the patient's symptoms have gone down. Now, there are patients who you may not be able to use non-steroidal anti-inflammatory drugs. You can consider using systemic corticosteroids, but remember, the dose of these steroids should be at most moderate dose. We are talking about the 20 to 30 milligrams, and just for a few days to avoid the side effects that accompany corticosteroids. Intra-articular steroids are also very effective for acute gout attacks, especially if you have one joint involved. Just inject it and the inflammation will go down. There are other medications that are used during acute gout, and one of them is colchicine. We are also all familiar with that. And for those maybe who are not yet aware, nowadays we don't use colchicine at those high frequent doses that were taught previously. We nowadays use colchicine at regular, usually twice a day dosing of about 0.5 to 0.6, depending on where you are. By 0.5, I mean milligrams. And you can use that twice a day to control a flare, especially in patients who already established gout. You can use colchicine to control an acute flare if they were not on colchicine already. There are other drugs here, which if you're familiar with the pathophysiology of an acute gout attack, you'll understand that interleukin-1 inhibitors and ACTH, the corticotropin, can also be used to reduce those flares. But perhaps at this level, you should be discussing with a rheumatologist or another sort of specialist to see whether it is needed. And it is particularly in patients who can't take all these other medications that are available. Okay, so I thought that this slide was also a good way of looking at things. This is the NICE guideline. So we've come from the acute gout, and we now want to look at what are our options in a chronic gout, and to first ask ourselves who we should treat, and then what are the options. So let's just look here at this NICE table that tells us that on this end here, if you have somebody who has many flares, they say usually more than 2 per year, but you also need to decide according to the patient's presentation, but at least 2 flares a year, or the flares are quite troublesome. Someone who has CKD, chronic kidney disease, someone who has tophi, who has tophaceous gout, and you may consider also with people who have very high uric acid. Even if they don't have these other things, you can consider putting them on uric acid lowering therapy. So not everybody who comes to you with acute gout requires uric acid lowering therapy. If it is the first attack, you can hold off and see how things develop before you put them on uric acid lowering therapy. But if they've had several attacks, or you have found these factors that we have discussed, then you need to treat them. And this slide suggests that patients who have CKD, who have tophi, they probably need to see a rheumatologist at least for initiation and management of that of their problem. Okay, so uric acid lowering therapy, there are several drugs. We'll talk about them here and there. And the other things in the table, of course, the paper is there. You can look at it when you're free. And these things are also just freely available. One can find them. Okay, so what are some of these drugs that we should look at? We're saying that if you're going to lower the uric acid, you can either use allopurinol or febuxostat. There really isn't a major preference of one over the other. There are some guidelines that give allopurinol as first line and febuxostat as second line when you're talking about the xanthine oxidase inhibitors. So majority of us are more familiar with allopurinol, but we are also all aware of febuxostat because of marketing, and the drug has been available in our space for some time. It is about cost. It is about other factors that you'll consider in the patient. So allopurinol, we are familiar with it. It is a good drug. It lowers uric acid. The only thing is that it is thought that we usually underdose it. So consider the fact that you need to titrate to target, because you want to get to a target of about 360 or 0.36 or 6, depending on the lab parameters that you're using. Febuxostat is non-inferior to allopurinol. In some studies has performed even better, but there's been this black box warning, I think, because of some studies here and there and findings here and there. There are worries about cardiovascular events, that it might increase the risk of cardiovascular events. So perhaps if a patient has had a recent stroke or a recent myocardial infarction, if you can, you may want to avoid febuxostat. But if you must use it, maybe there may be not much harm to it. So once you start your medication, you titrate it and you get to your target, and then now you decide. So the question here is, how long are you going to treat this patient? I think this is something that is still being discussed and debated, but the trajectory seems to be moving towards, let's treat these patients lifelong. If you want to consider stopping this uric acid lowering therapy, you can decide maybe you've not had a flare for 1 year, maybe your uric acid is a target, you don't have tophi, and you could try to stop, but a number of them will reflare. So we are moving towards the point where gout will probably be a lifelong treatment for those people, particularly with established gout, whom you've decided, I'm reducing the uric acid. So we are moving away from this business of allopurinol 1-2 months, and then you let the patient go and see from there. All right, so while you're initiating your xanthine oxidase inhibitor, then you can offer colchicine to prevent flares, because in the early stages of lowering uric acid, there tends to be flares. And if they can't use colchicine, you consider using NSAIDs. If they can't use NSAIDs, there are other factors that you could think about, but you want to, of course, consult those who are more experienced with treating those challenges. This slide is also a little bit repetitive. I just wanted to use it to point out a few things about the medications that we can use and other factors. So we've talked about who you should treat. Some of the things here I've updated as I was talking in the previous slide. And we've said that we have a target of uric acid and you need to monitor it, and you need to prevent acute flares by using mostly colchicine. And you want to, we've already talked about the acute gout management. And your choices then are, I can use a xanthine oxidase inhibitor like allopurinol or floxostat. Other choices then are the uricosurics like probenecid. There are other uricosurics, but some of them are thought to be a bit too toxic. And then you can also use other drugs like pegloticase, which is a uricase, but that one is also IV infusion. And consult also and work with your rheumatologist if you need to. Educate the patient, and even as you educate them also, though, don't be too preachy, because sometimes patients get discouraged and feel like it is my fault, I've been eating meat, and blaming themselves, but to assure them that there's also a genetic aspect, and to help them just to manage their sleep and remember to check for their cardiovascular risks. I just wanted to say one or two things as we come to the end of my talk, and I hope I haven't taken too much time, Dr. Tao. So I just wanted to mention that because gout is common in men, I just wanted to touch on the so-called health-seeking behavior of men and when you should initiate uric acid lowering therapy. So if you've met a patient and you've decided this patient qualifies for uric acid lowering therapy, in the past, we have taught that you initiate your acute gout management if they had come to you in acute gout, and then after 2 weeks, you start your uric acid lowering therapy so that you can avoid either another flare or worsening that acute gout. As we go on now, we are thinking that it may not be a crime, it may not be a bad thing to start your uric acid lowering therapy at the same time on the day that you're also starting the therapy for the acute gout. Because perhaps there may not be such a significantly increased risk of a flare or worsening. And also because we've realized that there are people who escape. Men have interesting health-seeking behavior. They're not very, what do you call it? They're reluctant consumers of the health system, if you can put it like that. And maybe it is because the health system does not meet their needs, but we need to understand that aspect. And so if you find this person, you just start them so that at least you're doing something for them before they take off, because some of them coming back after 2 weeks, there may be an issue with that. So let's keep that under consideration. We've again discussed diet, and I'll say again that diet is very important. You need to emphasize it, but you also need to remember that the contribution of diet is much lower than we think to the level of uric acid and to the other factors about it. Genetics do contribute a lot, but let us be supportive and help our patients to see how they can look into their diet and reduce eating sugary things, the meats, and just the healthy lifestyle. I think that works across all these non-communicable diseases also applies to gout. And then to help patients to reduce their cardiovascular risk, their weight loss, manage their cholesterol, manage their high blood pressure, help them to start exercising, and so on and so forth. So hyperuricemia. So we've talked about hyperuricemia, and we want to ask ourselves whether, so then I've met someone with hyperuricemia, it is asymptomatic. So what are you saying? Are you saying that this person should not be treated? At the moment, we are sort of saying that that person should not be treated, though there are discussions about the fact that hyperuricemia is not benign. Even if we're calling it asymptomatic, it may not be benign. So I know that all of us in practice, we tend to lower uric acid even when it is asymptomatic. But on this other side of the evidence and the science and so forth, because not all hyperuricemia develops into gout, it's not very clear whether you should just lower all uric acids. You have to try some lifestyle interventions and think of the other things that may be influencing it. These are areas of discussions. We can always chat about it in the question time. And so I want to thank you for your attention, and back to you, Dr. Etal.
Thank you very much, Dr. Naktari. Excellent presentation. We will hold the questions till the end of all the presentations. Thank you very much. Excellent presentation. Now invite Dr. Wino Omo, our pediatric rheumatologist, to make his presentation on juvenile idiopathic arthritis. Dr. Wino, you may share your screen. Okay, Dr. Wino, it appears Kiroti is, or she was trying. Are you ready, Dr. Wino? Or
I'm there. Yes. In a minute, I'm presenting.
Okay, welcome. So as we wait for Dr. Wino to share his slides, we could be, allow me to be speaking a little bit about World Arthritis Day. So like I had earlier mentioned, it's an important, okay, so Dr. Wino is here. So we will proceed with and listen to him. Thank you.
Thank you very much, Dr. Itau and the KNH team for the opportunity to share something about arthritis in children. It's something. Okay, so I hope that you can see my slides. They are not moving.
They should just move. Sorry, click it on your side.
Fine, sorry about that. So let me get started. So thank you for the opportunity again. And we are celebrating or commemorating the World Arthritis Day, where the theme is actually, it's in your hands, take action. And I do believe that we can do a lot by ourselves for those who are suffering or affected by arthritis. So that will be the outline of the presentation. But as a form of introduction, we know that musculoskeletal disorders are the most common cause of disability worldwide, at least when we talk about physical disability. And the causes of this range from rheumatoid arthritis, fractures, juvenile arthritis, and autoimmune connective tissue disorders. Juvenile idiopathic arthritis, previously called juvenile chronic arthritis or juvenile rheumatoid arthritis, but now the accepted terminologies globally is juvenile idiopathic arthritis, is the most common pediatric rheumatologic disease and a cause of long-term disability. Incidence of 0.8 to 22 per 100,000 and prevalence ranging from 1 to 4 per 1,000 in some places. And has been described in all races. So how do we diagnose arthritis? Basically, like any other medical condition, we have issues about history, physical exam, and use of diagnostics. So usually there is pain, and the pain, you need to know whether the pain is located in the joint or in the bones. Remember, arthritis is inflammation of the joints. So there will be pain in the joints, usually not in the bone. If the patient manifests with pain in the bone, then you need to think of something different. The pain usually is worse in the morning and is associated with limping or gelling or difficulty in walking in the morning. There will also be associated joint swelling in most cases. That is obvious, but sometimes it is subtle. So you may need to look more carefully. And I've already alluded to the issue of joint stiffness. And there may be deformity that is obvious. Other things to look out for are skin rashes, fever, weight loss, and sweating. However, these are only common in one subset of juvenile idiopathic arthritis. And any patient that manifests with fever and weight loss, then you need to think of alternative diagnosis and rule them out before you label the child as having a juvenile idiopathic arthritis. So JIA would really be a diagnosis of exclusion. And in a patient with fever and weight loss, you need to think about malignancy, you need to think about infections, you need to think about other connective tissue diseases like lupus. So when we talk about arthritis, we mean joint swelling. So if there is a swelling in the joint, okay, so if you can see my point, if there is a swelling in the joint, like in this case, in the wrist or in the knee, then we say you have arthritis. The other alternative definition of arthritis is tender or painful joint that cannot be stretched to the full range of motion. So either of those two, swelling or painful and is not able to stretch to the full range, then we would say that you have arthritis. This is just to show some swellings around the joints, and swelling of a toe, knee swelling, and then this is deformity. You can see this child is standing with the knees bent, so there's flexion deformity. So by definition, JIA or juvenile idiopathic arthritis is a clinical diagnosis. So we say it is arthritis in any number of joints, starting before the age of 16 years, and it must have been there for 6 weeks or more. And there is no other cause for the arthritis. So it is a diagnosis of exclusion, but of course the question will be how, there's no other cause, so you investigate for the obvious causes. So if, for example, it's a boy that manifests with recurrent bleeding from the nose, from the gums, then you are thinking maybe it could be hemophilia, and therefore you would investigate for hemophilia. If it is a girl, then obviously it wouldn't make sense for you to diagnose for him, to investigate for hemophilia, at least not the classical hemophilia, because from what we know, most of the cases of hemophilia occur exclusively in boys. Of course, there may be some exceptions. So juvenile idiopathic arthritis is a group of conditions. It's not just one condition. And therefore, we have what we call subtypes of JIA. And the most common subtype is oligoarticular JIA. That means that there are 4 or fewer joints which are affected by the arthritis. Then we have polyarticular JIA. Polyarticular JIA usually manifests with joints, more than 5 joints or more, which are affected by arthritis. And then we have these other subtypes called systemic juvenile idiopathic arthritis and a few other subtypes. This one called enthesitis-related arthritis is relatively common in boys. And I've highlighted those ones because those are the ones that we are going to talk about. So let's talk about systemic juvenile idiopathic arthritis. This is arthritis that manifests with systemic features. Remember what I just said, that if a patient presents with weight loss and fever, then you need to investigate for other diagnoses other than JIA before you land on JIA as a diagnosis. So these patients present with what we call quotidian fever. So it's fever that spikes once in a day and comes back to normal the same day, and then spikes the next day again and comes back to normal. And that is the actual pattern. And there may be hepatosplenomegaly. This one is just to show arthritis, swelling of the joints. And in addition to the fever, there's usually a rash. This rash is more visible during the spikes of fever. And then it sort of reduces when the fever goes. Then there may be lymphadenopathy, that's what they're showing here, and some features like chest pain or even pleural effusions. So basically, if a patient presents with arthritis, which we have already said is swollen joint or painful joints that are limited, and has fever and a rash, then one of your top differential diagnoses should be systemic juvenile idiopathic arthritis. Of course, the other things that might manifest with the fever and the joint pain include leukemia and other malignancies, which you should always keep in mind. So having said that, then I may ask a rhetorical question: do children get arthritis? And that is your answer from Kids Arthritis Foundation. Kids get arthritis too. So about 1.7 billion people in the world have musculoskeletal conditions, and we already said they're the most leading contributor to disability. And in Europe, there was this study that was looking at a systematic review that looked at the prevalence and incidence of JIA, and they found that the incidence ranged from 1.6 to 23 cases, depending on which country they looked at, per 100,000 children. That is below the age of 16, and the prevalence ranged from 3.8 to 400. So even looking at that with our own country, we have close to 50 million people, and almost half of those are below the age of 18. So if we are talking about 20 to 25 million of our people, and even one case per 100,000, that would mean we are talking about almost 25,000 cases of JIA in Kenya alone, at a rate of 1 per 100,000. So it is a relatively common disorder, and therefore there are many children who are in the communities who are suffering from juvenile idiopathic arthritis, who may not have been identified. So, globally, using World Bank data, these researchers found that we had around 2 million children below the age of 16 years in the whole world who are living with arthritis in 2017. They were using World Bank data. And this it translates to around 0.2% of all children in the world as having JIA, because the total number was around 2 billion, and 2 million of them had a JIA. So that is 0.1% of all children, which is about one in every 1,000 children having JIA. And just to note that in that study, the disease prevalence was greatest in Asia, followed by Africa. So these conditions are there in Africa, and they are relatively common compared to the rest of the world. That is just the same study now pictorially representing the same. And there is this study that we were calling a POCA study. I had the opportunity to participate in it when I was in South Africa. And I'm just bringing this to highlight that this one called systemic juvenile idiopathic arthritis in Europe, it is only about 7%. In Latin America, in Asia, and in Africa, it is more than 10%. Now, systemic JIA is important because its management is totally different, and the drugs that we use are relatively expensive compared to other drugs. And so you can actually see that the countries which have more resources have actually the more favorable types of JIA compared to the countries which have less resources, and therefore it means that we have a lot of challenges with accessing appropriate care for these children. So what about in Africa and in Kenya? We don't really have data, but there is a tunnel at least, and maybe soon there will be light at the end of the tunnel. We have the organization called PAPLA, which is Pediatric Society for African League Against Rheumatism. And we are currently in the process of collecting data from all over Africa. And hopefully in the next 1 or 2 years, we'll be able to show what the data shows for Africa. And we are honored to participate currently through Gertrude's Hospital, but soon we'll also seek for approval to collect data from Kenyatta National Hospital. So is limb pain always JIA? And this question I'm asking because many of the cases that are referred to our clinics, many of them are not JIA, they just have pain, and therefore which other conditions can actually present with pain in the limbs. I want to go back to what I said already. There are red flags. If there is fever, if there is weight loss, if there's pain in the bone, because we said arthritis is inflammation of the joint, so pain should be in the joints, not in the bone. So if you have fever, weight loss, and bone pain, then you need to think about malignancies and other things other than GI. There are also the benign causes where patients just present with joint pain, but this is a patient who is in perfect health, is running around, but complaints of pain, especially in the evening. The patient is growing well. Usually, when you test them, you find that they have very flexible joints, and usually that is the cause of the pain. And we just need to reassure the parents. Usually, the pain goes as the patient grows. There's also growing pain. Now, growing pain occurs in children about the age of 5 to 11 years. And usually they present with severe pain at night that wakes them up from sleep. They scream in pain. But the thing about this pain is that when you just massage or rub or soothe the child, within 10 to 15 minutes, the pain goes away and the child goes back to sleep, wakes up in the morning perfectly in good health without any evidence of the pain that was there in the night. And they are growing well. And this pain occurs very episodically and usually maybe once in a month or once in 2 months or once in 3 months. It's not daily, as opposed to the benign mobility pain. Remember also localized hip syndromes like Path's disease, a vascular necrosis of the head of the femur. So those may present with pain localized to the hip. So you need to think about those. If it is pain localized to the tibial tuberosity, usually in adolescents who are very muscular, then think about Osgood-Schlatter disease. Pain localized to the feet. Sometimes just tell the children or the patient in front of you to remove the shoes and step on the ground. You may notice that they have flat foot or very, very exaggerated medial arch, and that would be the cause of their pain. So watch investigations. Now, GIA is a clinical diagnosis. There is no diagnostic test for GIA. So many patients, by the time they are referred, people have done rheumatoid factor, people have done ACCP, people have done ANA. So these ones are not diagnostic, and neither are they used for screening of GIA. It is clinical. So only patients who have swollen joints lasting more than 6 weeks, and the swelling has started before the age of 16, and you have ruled out other causes, then you think of GIA. Once you have diagnosed GIA, that is when you do rheumatoid factor. This one is only used to classify them into rheumatoid factor positive and rheumatoid factor negative. SCCP is not routinely recommended. Most of the patients with rheumatoid factor are also SCCP positive. However, these two, when they are present in a patient who has been confirmed to have GIA, then they are poor prognostic features, and they also show that the patient is likely to have GIA into adulthood. So how do we manage? I hope I can finish in the next 5 minutes or less. So physiotherapy and occupational therapy have a role, as is pain management, because the conditions will be painful. Counseling, of course, there is this a chronic disease. The child is going to have disease for a long time. There are medications with their complications and the cost of medication, which are going to take every day, side effects of those medications, and sporting activities, going to school. So you need to do a bit of counseling for the patients and for the parents. So pharmaceutical management, painkillers, intraarticular steroids, but the mainstay of treatment is methotrexate. So almost all our children or patients with JIA, we start them on methotrexate. There are other DMARDs that can be added to methotrexate, like chloroquine, hydroxychloroquine, or sulfasalazine. And then there is this group that we call biologic agents. So this is how we do joint aspiration. Just put the needle into the joint and aspirate. Once you get fluid, it means they're in the joint. Remove as much fluid as possible and then inject the steroid into the space. So once you remove the fluid, leave the needle in situ and only remove the syringe, and then bring in your drug and inject it into the joint. Usually it is safe, but there may be bleeding into the joint if there is trauma. And sometimes we get this side effect of this hypopigmentation of the site of the injection because some of the steroid may track backwards. So biologics, these are agents that may be used, especially where the traditional DMARDs have not worked, but also in certain subtypes of GIA. So if you're dealing with systemic GIA, you may need to start biologics from the beginning. And just to say that recently we've had quite a number of our patients coming with the systemic type. The last 1 month in Kenyatta alone, we have seen not less than 3 patients coming with systemic GIA. And as we said, this drug, this one is treated with the biologic agents. This is an algorithm that is recommended by the SCR or in the USA, but which is used globally. So you may need to start interleukin-6 inhibitor. So this one is tocilizumab, is the one that is available. And it's there even in Kenyatta National Hospital, but of course somebody has to pay for it. It's relatively expensive, but the cost has come down, especially because remember, people are using it for COVID complications. Rheumatologists have been using that for forever. So we were just happy to allow the ID and the other teams to also join in the use of tocilizumab. Anyway, other than interleukin-6, we also have interleukin-1 inhibitors. Anakinra is not readily available, and therefore there may be issues to do with availability. But remember, it's a global world nowadays. If you have money or you have the resources, then the medicine can be sourced wherever you are in Africa or in the world. But these interleukin-1 inhibitors are much more expensive compared to the interleukin-1 to the interleukin-6 inhibitor. So what are some of the outcomes? Joint damage. This is one of the patients we were seeing somewhere in Cape Town. You can see the joints are damaged and the patient is wheelchair bound. So you may be wheelchair bound if you are lucky. If you are unlucky, you'll be bed bound or floor bound. If you cannot afford a wheelchair, there will be other joint damage. And then there's this chronic uveitis. This is a preventable cause of blindness. Therefore, all the patients who have JIA, we recommend they should have eye checkup every 3 to 6 months by an ophthalmologist or somebody who is trained to look at the eyes properly with a slit lamp. And this obviously is available in Kenyatta and in the major hospitals. And therefore, always it's recommended to refer all the children who have JIA to a center where they can have proper eye evaluation. Does JIA remit? Do children remit? Does the disease go away with age? So there's this study that we like quoting, though it is old, but there are others that have shown most of the cases of JIA will be there into adulthood. For example, if you have rheumatoid factor positive disease, 98% of these children after 25 years still had active arthritis. And this one is for rheumatoid factor negative, and that's at 80%. So most of the children with JIA will have arthritis. Therefore, let's avoid giving false hope, but rather give correct information so that the children can receive the best care as long as they are still sick. So what are some of the things that we need to be aware of? So greater awareness, I know we still need to do more in terms of creating community awareness and even awareness among health workers. And that's why we are grateful to Kenyatta for giving us this opportunity. And then there's the issue of access to drugs, especially biologics that I have said, they are relatively expensive. For any standard dose for a small child with the systemic GIA, for example, we are talking of almost 100,000 in a month. So that is quite expensive, especially if you have to do out of pocket. And therefore, we need to continue advocacy, especially NHIF, other insurance agencies to be able to help these children who have this disease to access care. So where do you get more resources? These are the centers in Africa where you have pediatric rheumatologists. So we have Kenya, Tanzania, South Africa, and the Arab world. And in West Africa, Nigeria and Ghana. And in Kenya, in Kenyatta National Hospital, Gertrude, Aga Khan, and the Nairobi Hospital, you can access pediatric rheumatologists. But remember, we have other rheumatologists who can and have been taking care of these children, the other rheumatologists, and also the rest of the healthcare workers who, it's a matter of interest. Once you show interest, then obviously you can acquire the skills to be able to take care of these children wherever you are. These are some other resources that you can access. PMM online, and this one shows and gives a lot of information, including videos on how you can examine children for musculoskeletal disorders. Then for patient information, remember nowadays there is Dr. Google and people Google and find all sorts of fun information. We do recommend that you refer your patients to Printo. So if you just Google Printo rheumatology, because there are other funny Printos, it will take you to this website. And there is very good information written in lay terms that is also good for health workers who are not rheumatologists. So you go in there and you find quite good information. And then there is, of course, APLA website, which you can use to access some information on what's happening in it. Thank you very much. And sorry if I've taken longer, but I do think that this was really a good opportunity for us to highlight the issue of arthritis in children. Asante sana. Over to you,
Yeah, thank you very much, Daktari. Just to mention as part that Dr. Wino is the chairman for the Kenya Pediatric Association and is the alternate chair of the Medical Advisory Committee in Council. He's doing great work for pediatrics in Kenya, doing research on vaccination, doing the registry. Thank you very much. Our next presenter is Geraldine Kirote. So Chola, you can be helping her load our slides. And Kirote is a registered community nurse with a diploma, who is one of the pioneers in setting up our rheumatology clinic in Kenyatta, which is now more than 10 years old. Has taken care of many people. As an individual, I'm very grateful to have all the services that she provided our meetings. And she's going to give us a talk on the role of rheumatology nurse. What is the role? Enable care of patients and improve their outcomes. So Kirote, you will share your slides. Achola, Nelson. In the interest of time, please share because we have like 20 more minutes to go.
Yes, Doc, can you see the slides?
Yes, we can see the slides, and thank you for sharing. So welcome, thank you, Nelson. Welcome, Dr. For your presentation.
Good afternoon.
So our official afternoon.
Thank you so much for this opportunity. And we are very grateful for bringing up the Arthritis Day. Now, my role as mine is about the role of a rheumatology nurse in the rheumatology clinic. Now, a rheumatology nurse specialist is a trained nurse who has a specialist experience in looking after patients' physical, emotional, and social needs. In other places, she's also called, or he is called, a clinical nurse specialist, rheumatology nurse practitioner, or liaison rheumatology nurse. The role of the nurse that now they work with people with all kinds of rheumatology related conditions. The nurse is supposed to provide education, counseling to patients and their caregivers concerning how to live healthier lives, manage patients' medications through health education, collaborate with and assist rheumatologists, physicians, and other members of the health care. This one in the clinic, we've started one of the health educations on the second Wednesday of every month, which we started last month, though we had only one patient who turned up, but now we have educated them on the day. So we are hoping this month we'll have a few patients so that we can continue with the education and counseling, and especially the patients who are willing to get pregnant, so that they are aware of what they are supposed to do. The other one is managing the side effects from the drug treatments, so that they are aware when they are going home with the drugs, what they are supposed to watch, and providing sooner appointments if required, especially for flare-ups. Because we have patients who are coming to the clinic after maybe they have some flare-ups, so we provide sooner appointments, or if it is the day for the clinic, they are seen. The other roles, in Kenya, we have a fewer roles than in other countries, because like in the developed countries, the nurses are allowed to practice with full autonomy through evaluating people with rheumatological conditions. They order and interpret diagnostic tests, prescribe treatment without restriction or oversight by a managing physician, and they work within the rheumatological team. But in our country, we are not yet there. So we are hoping that in the next few years, we shall be there. Because here, according to the Ministry of Health, then the nurse is not supposed to do that. But in other countries they are doing, we are hoping to do it with time. Something like that. What are that?
Are you done, Kirsten?
Not yet. Something. Down. I think that's
Okay.
Sorry for that.
It looks like you're done.
I think sorry for that. But most of the things you are doing in the clinic is just health education, the ones I've talked about. So the other roles for a rheumatology nurse, you've not yet started them, which you are hoping to start in a few years when it is passed by the parliament. I think that's all, and thank you.
Thank you very much. Much appreciated. Kindly allow me to introduce myself. My name is Dr. Tao. I am a rheumatologist, senior medical specialist at the hospital. I'm going to make the last presentation. The presentation is on caution in the use of NSAIDs. It's going to be a brief presentation. So the reason why we presented on NSAID is like in most of the people who treat patients with arthritis, people believe that NSAID is actually it's actually the treatment. And yet, yes, it is, but NSAID is just part of the treatment. It's not the final or the eventual treatment for arthritis unless specify among. So I'll go through a case and look at the role of NSAIDs in arthritis, and I'll mention about the adverse effects. So as a case, this is presenting a patient called JW, who was 65 years old. He was diagnosed to have gout for about 5 years. He was self-medicating with diclofenac. With, like Dr. Bacteria mentioned, the painful metacarpal joint podagra, midfoot swelling, physically an acute gout. But at that time, our acute presentation was found to have impaired renal function with accretion of about 400. Yeah, there were no other obvious causes for kidney impairment. He was hydrated for a couple of days, with no improvement, and he was not ready to. And he continued management of colchicine and urine lowering therapy, and the kidney function there was no improvement. But unfortunately, this patient now developed severe cordial chest pain, and then an ECG that reveals ST segment elevation myocardial infarction, he had a regional motion abnormality. He required coronary angio. Remember, this patient already has now kidney impairment as a result of the NSAID use. Now needed to be given contrast, and as a result of this, actually, the patient required dialysis. I just mentioned this to say that a simple condition as gout, which ideally well managed, it's okay, can actually lead somebody to very severe condition requiring now hemodialysis. So what is the role of NSAIDs in patients with arthritis? The role of NSAIDs include pain management. It has a role in the management of nociceptive pain as a result of inflammation. The other causes of pain, we have the neuropathic pain, we have the nociplastic pain. Those, when your assessment of the patient, you should ideally not use NSAIDs in those patients, but NSAIDs are useful for pain, nociceptive pain, which usually would result. NSAIDs are also useful actually in reduction of inflammation in patients who have inflammatory arthritis, gout. NSAIDs play a key role. And also NSAIDs are useful in disease modification in patients like spondylitis and spondyloarthropathy. And there's evidence to show actually that disease modifiers in this condition. This is the only time that we actually use NSAIDs for a long time, that sort of intention. So how long should we use NSAIDs? We should use NSAIDs for the shortest duration possible and at the lowest dose that guarantees both inflammation reduction and physical function. Therapy duration must be tailored to the patient profile, and the treatment duration is usually at least 10 days. Ideally, make it as short as possible. If there's no improvement after 3 weeks, then you actually need to switch off to another agent. The patients who use NSAID for more than up to 3 weeks, and like the patients who have arthritis, which have some inflammation, or rheumatoid arthritis, or the inflammatory arthritis, or patients who have spondylitis or spondyloarthritis, in which you're trying to do the disease modification by use of the NSAID. So what are the adverse effects of NSAIDs? The advantage is that we all know this, and the reason why I'm presenting is just to remind us and discover that it is important to remember the side effects. The cardiovascular system side effects, the gastrointestinal system side effects, kidney side effects.
Excuse me.
And these are related to both COX. Yes?
Excuse me, Dr. We're getting a bit of interference.
I disappeared?
No. We're getting a bit of interference from your end. We're getting a bit of interference from your end.
Is it echo or what?
There are some voices in the background. Hello?
Hello, and now?
And now we can still hear a bit, but your voice is a bit higher. So that's okay.
Okay. My apologies for that. So basically,
sorry, Dr.
I
Tao.
hope you got me.
Dr.
Yes?
Tao, maybe also,
Speaking?
I don't know if it's Geraldine's microphone was on. Maybe there was some background noises. I think she has put it off now. but there are some
Oh,
people
thank you.
talking in the background. Yeah.
Okay, my apologies for that. Sorry. So I hope I did. So let me go back to this. Let me go back to this slide with the NSAID adverse effects. And basically, is to go through the adverse effects will be in the cardiovascular system, the gastrointestinal system, and the renal system. And the major cardiovascular events are the major vascular events, the stroke and acute myocardial infarction. Gastrointestinal, as we know, gastritis, peptic ulcer, bleeding. We may get actually liver toxicity, intestinal disorders, and the kidney impairment, acute kidney impairment. Some patients actually who have been on NSAIDs will develop edema. They may develop hyperkalemia, high blood pressure, they may have proteinuria or nephrotic syndrome if they get an acute interstitial nephritis. The cardiovascular effects, so all NSAIDs are actually associated with increased cardiovascular risk, and the risk is highest on the 8th to the 30th day of use. Basically, doesn't mean that the patient must use the NSAIDs for a long time. And sadly, I've actually had 2 patients who needed to be on NSAID, one with psoriatic arthritis, and the gentleman now who had gout, and both of them developed MIs. So this is quite scary, and also has a medical legal implication if you're not warned the patient about the risk of this in advance. In a patient who has a prior acute myocardial infarction, there's excess mortality, up to 6 deaths per 100 years compared to those not on NSAIDs. And ideally, we should avoid all NSAIDs, those with prior cardiovascular events, or in those with increased risk of cardiovascular events. What about renal and adverse events? We should monitor renal function and blood pressures in all patients who are on NSAIDs, even both, be it COX selective or COX selective, and especially in those with existing conditions such as high blood pressure, renal disease, and heart failure. What are the factors that require prophylaxis in terms of protecting gastroprotections for PPI? Basically, we should use PPIs to protect the gastric protection in those with history of ulcer complications, in those who are more than 65 years of age, in those who have prior ulcers without complications. Basically, if you're combining NSAIDs with anticoagulations, in those who are need to be on aspirin or clopidogrel, or as I mentioned, on chronic. So for renal adverse effects, the risk factors will be people who are more than the elderly 65 years of age, those with already existing chronic kidney disease. Incidentally, in a survey done, many patients actually who had CKD were actually found to be on NSAIDs. And ideally, patients with CKD should never be prescribed for NSAIDs because the NSAIDs will cause progression of it. You should always also assess for kidney impairment, and many doctors should recognize it early and stop. As a case in point, a patient recently worked out. He had been using NSAIDs on his own at home. His creatinine at presentation was about 260, and on stopping the NSAID, actually the kidney function normalized. But if he had continued with the NSAIDs, then he had a risk of developing chronic kidney impairment. The other risk factor because adverse effect is if you use NSAIDs together with the ACE inhibitors or ARBs, if you use high doses in patients who are on NSAIDs and get dehydration, and presence of comorbidities like diabetes, hypertension, heart failure, and stroke. Now, in elderly patients, we usually try and avoid using NSAIDs. And one of the ways to mitigate this and to decrease the adverse effects of NSAIDs is to use topical therapy. And for the joints of the hands and the knees, the topical therapy that includes maybe diclofenac or tofenet or any of those NSAIDs has been found to be effective. But there are trials that confirm actually that it's effective, and therefore it's advised in elderly patients. And absorption of the drug, though, is minimal, occurs, and sometimes if a patient who has a very high risk
prostate disease, then it is something to consider. Is there any role for combination therapy? Like in this market, we have many NSAIDs combined with other drugs. Yes, so we can combine NSAIDs mostly for pain control together with paracetamol or opiates. But you should not combine more than one NSAID, meaning that don't combine an NSAID with another NSAID because of this risk of toxicity. It's a common happening in Kenya, and that is risky because then you can increase the adverse effects that we have mentioned earlier. Also, avoid combination of NSAIDs with low dose aspirin because one, it actually makes the aspirin ineffective in terms of now preventing the risk. We know the low dose aspirin is antiplatelet, and that antiplatelet action is mediated by thromboxane. Higher doses of NSAIDs actually affect this and makes the aspirin not effective. The other bit, of course, is you should use NSAIDs with caution in patients who are on anticoagulation. Sorry if there was any interferences, but in summary, what I'll just say is that NSAIDs are actually useful in the management of pain and inflammation. Remember, NSAIDs are only disease modifying in spondyloarthritis or in patients who have ankylosing spondylitis. In many of the other conditions, NSAIDs are only useful for pain control, and therefore they do not change the general outcome of the disease in the future. And always, every time you are going to prescribe any NSAID to any patient, please remember about patient safety. Ask yourself, is the benefit that they are going to get from the drug that you're giving bigger than the adverse effects and the loss that will result from it? Thank you very much. So I'll now ask Dr. Nakitare to spearhead this remaining part of the meeting. We'll look at questions and we can answer it. So Nakitare, please share this part.
Okay, thank you, Dr. Tao. Thank you to everybody who has stayed on for this long and to the presenters. We'll quickly try to answer a couple of the questions there, and I'll pick some from the chat and maybe assign them to some of the members of the panel, and then we can just answer them one by one. So there's a question there about why gout is prevalent in men more than in women. So I'll handle that one. And then there's a question there, what is the impact of methotrexate on growth in children? Any studies? I'll hand that to Dr. Owino to handle that. There's a question there about managing, how do you manage arthritis in pregnancy? Maybe Dr. Tao, if you don't mind, you can make a quick comment on that one. There's also a question there, well, I don't know if it's a comment or something about in condition like hypertension, but the question is not coming out clearly, so maybe we'll leave that one alone. And then there's a question, which is advisable, diclofenac or etoricoxib? I think it's a question about what is more, is there a preferable NSAID, in other words? And the question surrounding that diclofenac and etoricoxib, I think it's the question about how long one should give NSAIDs without worrying about side effects. I assume that is the question. There's also a question here about physiotherapy and exercise in osteoarthritis. Is it helpful? I think we can safely say at this point that it is helpful, but maybe I'll handle that question at some point. And then there's another one, for how long are we supposed to give uric acid lowering therapy as far as gout arthritis is concerned? So I'll handle that. Okay, so what I'll do is that I'll ask maybe Dr. Owino, if you're there, you can handle the question on methotrexate in children. That is there an effect of methotrexate on growth in children? Are there any studies? Dr. Owino?
Thank you, Dr. Nakitare, and the person who has asked the question. Sorry, I can't see the name. But methotrexate, just as a background, is a drug that is used for almost all the children who present with arthritis, and not just for JIA, but any other condition that presents, any other autoimmune disease that presents with swelling of the joints. We actually use methotrexate. And methotrexate is also used for almost all adults with the cases of juvenile with rheumatoid arthritis. So just to say that this is a drug that is has been used very widely for a very long time to treat arthritis. Now, going back to the specific question, I'm not aware of any specific studies that have looked at the effect on growth, but we know the various side effects that are associated with methotrexate. That is GI issues like nausea, vomiting, but surprisingly, these are not common in children at all. We have had very few children who manifest with this kind of manifestations, unlike in adults. Then there are just the other side effects that should be known to most of us, like anemia, because of partly its effect on folic acid. And usually we give folic acid partly to reduce the side effects of methotrexate. And there may be issues with bone marrow depression. So you may get anemia or bone marrow suppression of the other cell lines. And then, of course, more importantly, possible hepatotoxicity. Usually, we advise the patients to just look out for any jaundice or yellowing of the eyes. And if that happens, they just stop the drug and then contact the clinician or the health worker. Most of the time, you are able to restart the methotrexate. But if there's a reason to be concerned or that there is a coexisting liver disease, then you don't give it. So basically, those are the main side effects that we look out for: liver issues, bone marrow suppression, and GI side effects. And of course, for adolescents, as they grow into that possible age bracket of weight of becoming pregnant, of childbearing, then you have to advise, because obviously it is likely to be very teratogenic. So the effect on growth is not a major concern, and I'm not aware of any studies. Thank you.
Okay, thanks. Dr. Owino, before you get off, I just want you to answer one that has just come into the chat. Does uveitis indicate progression of arthritis, and what is the best treatment for uveitis in GAIA and AS? If you can give a very quick.
Okay, yeah, thank you very much. Uveitis is a cause of preventable blindness in children with arthritis. So yes, it shows poorly managed arthritis, whether there was no management from the beginning, or you are giving incorrect doses or incorrect medication, or the medication that was previously able to control the arthritis is now not able to control the arthritis. So yes, the direct answer is that it is a sign of poorly managed arthritis or even progression of the disease. Correct management depends on the severity. Usually you start with the topical steroids, eye drops, but because this may signify systemic disease, you have to be on methotrexate and generally the other treatments to ensure that the disease, the GIA itself is well managed. Now, if you present with the uveitis other than methotrexate and the other drug that you use to manage GIA and the topical steroids, you would also give systemic steroids. But where there is a severe and sight-threatening disease, then the issue is you need to give biologics. And one of the main biologics we use is adalimumab. This is available in Kenya, but as we said, it is available anywhere, provided you have the resources. Relatively expensive if you have to buy from pocket, but it's available. So the treatment depends on severity, and for the very severe cases, we need to give them biologics, specifically adalimumab, but there are other biologics also that we use. Thank you.
Okay, thank you, Dr. Owino. I'm just going to move on to Dr. Tau to answer. I'll probably give you 3 questions, Dr., if you don't mind. The first one is, how do you manage arthritis in pregnancy? Maybe make a comment on that. The second question was concerning the presentation on NSAIDs. I think what I interpret is that this person wanted to see if there's a preferable NSAID, and they said, which is advisable? Is it diclofenac or etoricoxib? So in general, some NSAIDs safer than others, and how long is too long in terms of toxicity? And then the final question I'll give you, if you don't mind, give a quick comment. Or are there any roles for supplements in management of arthritis, glucosamine and such? Dr. Tao?
Thank you very much, Dr. Nakitare. The first question will be on the NSAID. Unfortunately, in terms of toxicity, all NSAIDs are the same. The marketers might actually give us an impression that one is safer than the other one, but at the end of the day, if you look at the systemic, the meta-analysis and the systemic and the systematic analysis of the meta-analysis, all the NSAIDs are the same, unfortunately. But some might be more potent in terms than others in terms of pain control, like ketorolac might be the more potent one, but in terms of side effects, they are the same. In terms of pregnancy and arthritis, the drugs that are safe for pregnancy, and this is called a shared decision where the patient and the doctor both sit down and decide whether the patient is okay using the drugs. And remember that some patients with rheumatoid arthritis actually will get remission in the course of their pregnancy, but you sit down together and agree. And if a patient has a flare or the patient requires treatment, then the drugs to use include salazopyrin, hydroxychloroquine, azathioprine, and the NSAIDs may be useful, might be safe in pregnancy, and actually the glucocorticoids, the steroids. So those are the drugs that you can use in pregnancy. In terms of the use of glucosamine, chondroitin, and the rest, there is no evidence to show that they are disease modifying, but there is evidence from studies, and most of it are from Asia, that show that it has improvement in terms of pain control, and sometimes then enables one to avoid using anti-inflammatory drugs. The NSAID use, I think, is patient dependent, and the aim is to use it for a short period as possible, depending on the patient's symptoms, except in patients who have like a spondyloarthritis or ankylosing spondylitis, where you may actually use NSAIDs for a prolonged period of time, because in this context, then it has been shown to be disease modifying. Thank you.
Okay, thank you, Dr. Tao. I'll just handle one or two more questions. One is about why gout is prevalent in men and women. Comment number one is that premenopausal women have estrogen, which is thought to be uricosuric. And then the other issue is about the handling of uric acid is made, there may be gender differences between men and women. So those genetic differences, those things that we touched on, the transporters and the metabolism of uric acid, there may be differences between how they're handled in both of the genders. The other question was how long you give uric acid lowering therapy in a patient with gout. We talked about that in the presentation, but as a general rule, we are saying that we are moving towards a lifelong treatment with uric acid lowering therapy. One can consider stopping it if one has had flare-free gout for at least 1 year, but one should expect that in the next few years, you may have a reflare. So lifelong is the direction that we are moving. I see that there are one or two other questions, but I think that we have run out of time. This is the time to end. So hopefully, we'll probably try to type an answer for these other questions. But let me just take this opportunity to thank all of you, to thank number one, the presenters, Dr. Tao, Dr. Wino, myself, Dr. Nakitare, and Nurse Geraldine for taking their time. We also thank the platform provided by Kenyatta National Hospital, and we thank the participants. We are happy to disseminate knowledge, and we are happy to have you here, and we hope that you will continue to attend these presentations. I'm not sure if there are any other announcements from the KNH research team side before we close. Anything from that side? Okay, so if there's nothing, then we thank you all for attending, and we wish you all a happy or informative World Arthritis Day. Please remember to be aware of the things that we've spoken about today, and we'll see you next time. Thank you.
All right, thank you, Dr. For the session as well as the presentation. I would like to address people who've been asking where they could get the recordings or the slides for the session. Apologies for that. To access or rather to watch the previous webinars that we recorded, kindly visit KNH-UoN-webinars.knh.co.ke. There you will find a tab with recent webinars, and they are categorized according to they're classified according to the topics we've held previously. So you can see here where you go to recent webinars, there are these tabs. You can look at cancer, you can look at COVID-19 sessions. We've had medical symposium, conferences, and other webinars we've held during the year. So you can always revisit, and in case you missed, you can always get to learn more. For CPDs, COC, your lists are normally sent to the council for accreditation. So you will visit the portal and see your CPD status. PPB, kindly visit the portal, subscribe for the events you haven't subscribed for. Most likely you haven't subscribed for the events. That's why you haven't received your CPDs yet. KMPDC, you will be receiving your CPD points for the session within 2 weeks from when the session is held. And NCK, your CPDs are sent within a day, and they will expire within 48 hours. So that is all from the KNH webinar team. Thank you for joining us, and do have a good day.
Thank you very much, Nelson. Thank you all.